They have a congenital brain malformation. They have a vascular malformation. They have a traumatic injury to their brain, right? So that can be the source of a seizure, right? And then your other type of epilepsies are those that tend to be what we call idiopathic, or there's no apparent reason for them. There's no structural abnormalities, right?
So I have epilepsy?
I think you may have epilepsy, yes. Given the EEG results and the events that you've had, right?
And why would it just now show up?
It can show up at any moment, any time. But for all we know, this could have been going on for a very long time. Did you had a routine EEG at some point, right? They did a routine EEG.
I don't know what routine means.
So when we spoke the last time, you went to the emergency room, and they did routine blood work, and that was normal. And y'all mentioned that they did an EKG and an EEG that was normal.
Like the one they put on my brain. That
Yeah,
in
they
the
put the
emergency
leads.
room, yeah.
So that was they probably recorded that for 20 minutes, 25
Yeah,
to
it
30.
wasn't long.
Yeah. And so, yes, good. And so a normal EEG does not exclude the diagnosis of epilepsy. Meaning if I put those leads on your head right now for 10, 20 minutes, it could be normal. But maybe when you take them off, then it's abnormal. Oh, then it's normal, then it's abnormal. So those bursts can occur once a day, twice a day, once a year, once every.
But if you said she was having it every 2 seconds, or they last 2
they
seconds?
were lasting
Yeah,
2
2
yes,
seconds.
but they were kind of scattered and throughout. So
It was like a routine of anything?
No, we did an ambulatory EEG, so we got like 19 hours of recording, and so so a lot of times when you have a patient that you suspect they're having seizures or they've had these events, and a routine EEG is normal, then you have to say, well, let's increase the sensitivity of that test. You just did it for 20 minutes, right? So how do you increase the sensitivity of that test to make it more powerful? You increase the duration time that you record. It's like you go fishing and you leave your fishing pole in the pond for maybe 20 minutes. But if you leave it in there for 19 hours, then you might get one.
Yeah.
You see? And that's kind of like what you do. It's like the same thing what they do with the heart. You do an EKG, it's like 2 minutes or 3 minutes, and then, but we still suspect that you might have an arrhythmia. Let's leave it on for a month. So they put a Holter monitor on you, and they leave it on there. I mean, I've seen them leave it on there for months on end until they can capture something.
Right.
You see, but typically, with epilepsy, the first presentation will be some kind of event that they had, or some kind of something that's unusual that happened, or a lot of times, like there are certain types of epilepsies that will present with cognitive decline. And so a lot of times that's why we see them. They're worried that they're not doing good.
Oh, is that why you were asking about school?
Yeah, yes, because there's something that's called epilepsy comorbidities. And so a lot of times that's how they present. They don't present with that's a seizure, you see. No, they present with, because in the background, what you don't know that yet is that they have these abnormalities on their EEG, right? Well, that over time can cause brain dysfunction, you see. Because every time that burst happens, the brain it's misfiring.
Yeah.
You see, so it's not doing what it's
So the
supposed
medication
to
will
do.
prevent that from
The
causing
hope,
future
yes.
damage.
The hope is that EEG normalizes at some point. The hope is that you prevent them from having clinical seizures, which is like let's say the EEG is abnormal. It's abnormal, but you don't know that, right? And then boom, this patient starts having clinical seizures, and that's why they're seen first, right? And so when you look at the EEG, you go, okay, you have these abnormalities, but that could have been there for years, you see, until boom, the icing on the cake happens now, because that activity is more prevalent now. And those bursts now, they want to come out with more power, and they want to last longer.
Does it build like a neural pathway to
Good question. Yes, that's it. It's called kindling. It's like you come up to the edge of the forest and you can't make your way in, but you cut a trail, right? And every time you come up to that forest, oh, there's a trail here.
right.
Oh, now there's a road.
Right.
So the brain just wants to go down that clear road.
Yeah.
So it forms these neural pathways that are not good neural pathways, and you're trying to shut down those neural pathways. Does that
Okay.
make sense?
Yeah.
And you want that brain to solidify good pathways. And so that's what you're trying to do. That's the hope, at least, that you're trying to accomplish with these medications, right? Of course, a third of patients will declare themselves to have intractable epilepsy.
Intractable?
Yes, meaning you're on 2-3 drugs and we can't stop your seizures.
Oh, okay.
Yeah. But epilepsy comorbidities is just baggage that comes along with that brain misfiring all the time. It's like if you have an arrhythmia and you have this.
So one thing
Yeah.
we've noticed
Uh-huh.
her entire life is incredibly sweaty and shaky hands. I mean, way more than normal. I've bought her medications to try to make it go away, and nothing seems to work. And I just wondered, could that have anything to do with it? She also has anxiety, and she's on an anti-anxiety, depression medicine. But the shakiness is like, all the time, and then just always sweaty. So I don't know if that's not a comorbidity, but maybe it's something that.
I think that may be something different.
Okay.
Yeah. But does she have depression or just anxiety?
Yeah, they gave her Zoloft because I think it takes care of kind of both of those.
Okay. And that's been helpful though, the Zoloft? Okay, good. And so the Keppra won't interact with that, okay? Yeah. And some of these medications that we use for seizures, they're mood stabilizers.
Well, that's kind of why I asked about Neurontin, because they tried putting me on Neurontin once as like off-label use, but I had a bad reaction to it, so I didn't take it for very long. It actually made my mood go way south.
Sometimes they'll have what's called a paradoxical response, and Zoloft can do that. You're trying to treat anxiety, but yet that medication, one of the side effects is potential anxiety too.
Oh.
So we're all kind of wired a little bit different and interact differently with these medications.
She's gotten better, but I also think she's grown out of some of it. I think she's able to cope with things better now than she could when she was 11, 12, 13.
Yeah. Now the other thing is your MRI. They're describing a small crural cistern cyst.
What was the MRI?
The MRI your brain.
The machine.
Yeah, you went into that machine, made a loud noise. Yeah. So you have a small cyst. They think it might be an arachnoid cyst, which is a benign. We see that all the time. It's just a benign cyst. But the radiologist, they want to. They're recommending repeating it with contrast.
Okay.
And
just to rule out anything.
Yeah, just to make sure there's nothing else. Yeah. And I don't think this is associated with what's going on in
a
her
cyst,
EEG.
like in my brain.
Yes.
Like literally like a cyst.
Like a small cyst. It's just a pocket full of clear liquid. Yeah, CSF. But that's frequent though. We see that a lot of people have cysts. They have
and no side effects from it.
Most of them tend to be asymptomatic. Can arachnoid cysts become symptomatic? Yes, but they can disappear also. Sometimes they just self-reabsorb and they don't cause any issues. And a lot of times they're just incidental findings. You're doing an MRI because the patient had headaches, and lo and behold, they have a little cyst. But it's not the cause of their headaches.
Does it say what part of her brain it was in?
Yes, it's in the crural cistern. So it's kind of like where the cerebellum is. It's just like a little bit on top in the center, towards the back.
Okay.
So, and it doesn't have any mass effect. So it's not like a cyst that's tight and pushing other tissue, you see.
Yeah.
But
what size is it? Did it say?
They didn't mention the size.
Okay.
Yeah, I was looking for a size, but they didn't put the size. They didn't measure it, but they mentioned no mass effect. So if there was mass effect, they should have measured it.
Right.
But a lot of times it'll be a cyst, and then it might just might be far away from the gray or white matter, but if it grows, it can impinge on the brain that's next to it, and so it can disrupt those pathways sometimes. But they don't mention any. There's no mass effect, so that's good.
Okay.
And so let's repeat that with contrast, okay?
Mm-hmm.
And then we'll get you on the Keppra, okay? And we'll just start you on a low dose, okay? And hopefully you won't have any more of these events, all right? And that's good.
Is she allowed to drive if she's on this medicine?
Yes, on this medication, yeah, you can drive. Mm-hmm.
Okay.
You may or may not. Keppra is the least sedating one, and if they do have a little bit of sedation, after a week or two it goes away. But I've never had to stop Keppra because of sedation.
Can she take it at night?
Yes, it'll be twice a day.
Oh,
okay?
twice
in the
a
morning
day.
and at bedtime. Yeah. So yes.
And it's pretty important not to miss, right?
Well, for a couple of reasons. One is you want steady state of the medication, right? And then if you reach steady state and then you start missing dosages, then you're kind of like opening the door for a possible seizure. You see, so you're potentially facilitating a seizure to come in.
Right.
And if that happens, then it's 2 more years from there.
Mm.
You see?
Mm-hmm.
And not to mention that you don't know what kind of seizure is going to come through that door.
Does it have to be consistently at a certain time every day?
No.
Okay, so
if
it's not like birth
if
control.
it's an hour or 2 or 3 hours is fine. Oh, it's been 3 hours, I forgot to take it. And then just go ahead and take it. Keppra is very forgiving. I mean, you can triple the dose and it's not going to cause any issue.
And how often will she come in and do more EEGs?
Yes. So what we're going to do is I'm going to get her on a solid dose of this, and then after about 3 months or so, we'll get another EEG.
Okay.
Yeah, make sure we try to capture sleep. If we have to do another overnight, we'll do that.
Oh, you're just talking about the one you do here.
Yeah, we just do a routine for now. Yeah.
Okay.
And then, yes. So the important thing is, of course, when you're around water, don't go to the beach by yourself or don't get in a pool by yourself. Just make sure someone's with you, comfortably with you. They don't have to be like this, you know.
But yeah, if they see you face down, they probably need to come get you.
Yeah, exactly.
Okay.
And then.
And how quickly does this Keppra actually start working?
Oh, it's the half-life of Keppra. So steady state is in about 5 days.
Okay.
Yeah, 4 to 5 days is steady state. So it's fairly quickly. The half-life is not that long with Keppra.
Is there a name for this type of what you think she has?
Yes, I think she may have a generalized or idiopathic type epilepsy because of the. And idiopathic means that most likely is genetically determined as opposed to a gunshot wound.
Oh, okay.
Does that make sense?
Right.
Yeah. And
I don't know anybody in our family though that has.
And there doesn't have to be. It can skip generations.
Yeah.
And
Okay.
I'm gonna put an order in for. What pharmacy do you use?
The Publix in Navarre.
Publix in Navarre.
The OG Publix, not that new one. I don't even know. There is a new one that just went in.
I don't know which one.
It's called OG.
No.